Hello and welcome to another episode of the program Healthy Living on Trust Television. I'm Aisha Salihu. It's been reported, and according to the College of Medicine, University of Ibadan, lupus is a widespread disease in Nigeria with over 100,000 cases identified each year. Again, the Lupus Foundation of America estimates that 1.5 million people in the United States of America and at least 5 million people globally have lupus. However, lupus can affect people of any age, but it is most commonly diagnosed in people between the ages of 15 and 45. Approximately 90% of these diagnoses are women, according to experts. We'll go over now to Dr. Mariam Bakare, who is going to give us more perspectives on this particular disease with 1,000 faces. Welcome to the program, Dr. Mariam.
Thank you very much.
Yes, I'd like to know very quickly, what exactly is this lupus disease that has been lurking around for a number of years now, and then a lot of people are not even aware of it? I'd like to hear from your perspective.
Okay, thank you very much. Lupus, well, that's a short name for it anyways. The full name is systemic lupus erythematosus. It's a chronic autoimmune disease that can affect different parts of the body. And when you hear autoimmune, it means a part of the body identifying another part as strange or foreign, thus attacking it. So like mistakenly attacking self, kind of. So it could be very debilitating.
Okay, so I know that just like you said, it somehow maybe sounds strange, but it's been there.
Yeah.
It's just that people are not aware of it. But then how
Exactly.
then do we detect the early signs, maybe symptoms of this particular disease?
Oh, well, for lupus, taking from your words that it's been there, but not so many people are aware or know about it, because at some time it presents like the normal malaria that a lay person knows, and then they end up being treated for malaria, typhoid, because sometimes they have fever, which is high temperature, someone with malaria can have, and other times they have joint pains and swelling. Then there are some classical things a person can experience. One of it is what we call the butterfly rash. We call it mallow rash over the cheeks. And one other thing is there's what we call photosensitivity. Not everybody really, but quite a number of people with lupus, when they are under the sunlight, the sun rays, it really burns. It gives them this burning sensation, amongst other things they could have. They can have mouth ulcers, sore throats, they can have chest pain. Remember I said it affects different parts of the body, meaning it's systemic. Different systems of the body can actually be affected. So when someone has some of these classical features, then you may have to present to your doctor. But I can tell you, really, there's still this diagnostic dilemma with lupus because of this overlap with some of the constitutional symptoms you have in other disease entities, the common disease entities. So they don't really get diagnosed specifically. But if they are lucky enough to meet a physician that has a high index of suspicion for lupus, then you'll be able to go further with your investigation. You know that we doctors, we don't just, apart from this chit chat we do, we go further to do some laboratory investigations. There are some specific ones which you can go, you can request for, and then the patients will get a diagnosis, and then you go further to treat. So you can't really, I can't look at you and say, oh, you've got lupus. You can't look at me and say you got lupus. You can suspect based on some things.
Okay, what then would you say are the causes or perhaps risk factors? Because someone would want to know, is there a condition that is predisposing me to this lupus, or is it coming over something else?
Yeah. Again, I'll go back to the name, autoimmune. It doesn't mean that you've done something. There are some things you can tell someone. If I tell someone, okay, I've got a liver problem, even a liver person can say, oh, have you been drinking? Are you an alcoholic or something? How did you damage your liver or something? But for this, you really can't say. But there's an interplay of some factors that can make one susceptible. There's the genetic factors with common environmental factors, and then some hormonal factors. The genetic factors, it's where, for some people, they are susceptible to this based on some history. It could be a family history of some rheumatologic disease entity. Most times it's not just lupus. When you talk about lupus, we have other disease entities that can even mimic And in fact, sometimes there's something we call overlap syndrome, meaning you have a bit of lupus and then you have a bit of Sjogren's syndrome or some other disease entity that's like in the same family brackets. So the environmental factor too is one thing. I think at some time we've had a patient before that she said it's when she started dealing in pains, house pains, that she had the triggers. So it's been there quiet or kind of, silent, and then this triggered it. The pains thing, the obnoxious chemicals really triggered it. And then stressful situations can actually be a trigger. And the hormonal factor there is there's female predilection for lupus. Fine, some men can also have lupus, but it's more. If you've really done a survey, you'll see that it's mostly women, and a few times you have some men coming down with lupus. Some have adduced that to the estrogen women have, and then so you see it's more in childbearing, women of childbearing age. So you can't specifically say this is the actual cause.
You did mention hormonal factors, right?
Yeah.
And then I wanted to find out, hormonal factors and genetic factors. Is there a particular race of people that you can say, okay, for this race, lupus, you can see a high rate of lupus tendencies in this particular race?
Oh, well, none that I know of. We've seen lupus in the blacks. We see it in the whites. We see it in Caribbeans and the Mediterraneans. But for us in our climb, the awareness, just like advocacy is just now, it's growing, and maybe in recent years. And then people are now more aware that, oh, there's something like this. That's what makes it look like it's coming up for us. It's been there. So there is really no racial predilection, because it's not like, unlike when you're talking about sickle cell disease or something, it's okay, we have so many areas still looming around in Africa, so they still have a high rate of sickle cell disease or something. It's not like some other disease entity. There's really no specific racial predilection when it comes to lupus. It's a respecter of no race anyways. Okay.
At what point would you say, okay, this is a critical case of a lupus disorder because it has affected maybe the lungs, the kidney, the heart?
For lupus, it's a very debilitating disease situation. It can affect you from the head to toes. Part of the symptoms I didn't mention is you could have hair loss. You could have neurological affectations where they exhibit some psychotic symptoms. They can have memory loss. They can be confused. They can have seizures. That's the convulsions that people see. And it can have respiratory symptoms. There's something called pleurisy. They breathe in and then they experience pain, they cough, they experience pain. And unfortunately, it could also affect their kidneys most often. There's something we call lupus nephritis, and at that point, you can just imagine the patient will be critical. Their blood level is low. A whole lot of things would actually become abysmal about the patients. And like I also said, some are just lucky if they have early diagnosis. You can actually nip it in the bud, at least be able to modulate the disease progression. But some are unlucky that at the time you're picking them up, they're pretty bad. They already have their kidneys bad, and it now becomes a kind of palliative kind of management for them. So it's a very debilitating situation. So what I will say to really attend to that question is, you're like, at what time would you say is critical? At every point in time you feel you have something that looks like, you don't wait on it. There's no watchful waiting. Let's see, maybe it would really transform into something big. No. Because remember, it's not something you can control yourself. It's about the immune system. It's about self-attacking self. It's not going to tell you this is when I'm going to come for the lungs, this is when I'm going to come for your kidneys. So at every point in time, lupus should be considered critical enough for you to seek care. Early diagnosis, buys you more quality life.
But then I like to know what medical conditions would let's say patients present with that you can suspect perhaps there is the lupus immune maybe disorder there too.
Okay. I've had patients who, in fact, in this situation, she just comes and then, oh, I've been sick, I've been feeling sickly lately. Do you understand? I've been visiting the hospital, I've been taking anti-malarials, it seems not to be working. And then by the time you interact better, you say, okay, the joint pains are there. So sometimes they come with joint pains and swellings. Sometimes it's body swelling. Other times they tell you when I pee, it looks turbid, it's whitish, it's foamy, maybe the kidneys is already getting damaged. And by the time you check, they tell you they have mouth ulcers, there's hair loss. You remember I said high index of suspicion by the physician really goes a long way in helping with the diagnosis. So you now go further to do investigations that will really confirm, or you'll be able to rule out, okay, it's not this, it's just a common thing. So it could be just joint pain sometimes. Or they could just tell you, I notice when I'm in the sun, it burns. I really can't bear it. And then I notice some rash. It could be on the face, which is classical, the butterfly mallow rash, or they say areas exposed to the sunlight, like on the face, the torso, depending on the kind of attire the person wears often. So they could just present like that. And then you now go further. Normally in the hospital, the physician wants to do 1 or 2 investigations. You do a full blood count, you're seeing a very low white blood cell count, amongst other things. And then you're like, okay, I need to go a step further. This could be lupus. So your history, interaction with the patient would also give it away many a times, if the patient is lucky enough.
You did mention earlier that it is predominant in women of childbearing age. It's not like men do not have it also, but it is more seen in women of childbearing age. I'd like to know, does this in any way affect fertility, pregnancy? Because I know there's so many conditions out there. The doctors will tell you because you present with this. So in another way, it's why you're unable to bear a child, conceive.
For lupus, I wish I could paint a picture of someone with in a very critical state of lupus. In fact, having a baby is the last on the mind when they are very critical. But what happens if you're very lucky to, diagnose the patient early? There could be progression. Sometimes a few lucky patients go into what we call remission, and it looks like, oh, I'm symptom-free, I'm good. So those that really progress and they're doing poorly, it's not just a disease entity. It doesn't prevent them from getting pregnant, but sometimes the medications you want to use would necessarily require you telling them, if you're pregnant, you may not be able to use this medication, so that means you may have to bear this pain for longer, or whatever. Let's see, alternative measures. Or if you're planning to get pregnant, could you just use some form of contraceptive so that we can at least, take care of you and make you feel much better before you can conceive? So the disease entity itself does not prevent you from getting pregnant, or does not cause subfertility, whether for the woman or for the man. But the hormonal factor I said some are adduced to the estrogen. In women, we are the ones that have estrogen, and explains part of the reason why we go through some reproductive cycles. So some have explained that because of the estrogen in women, that's why women have it often. But it doesn't mean they won't have a baby. I have patients. In fact, there's a story of a particular core member. Then, she came, but she was lucky. She was referred to my chief, then the rheumatologist, whom we worked together. We diagnosed her, and she started. Remember, it's a spectrum. She was on the light spectrum. We were able to catch her early. Let me use that colloquial term. And then we gave her medication, and she did very well. She got pregnant. Before I knew it, she had a baby, and then, she was happy. You understand? Because aside the medications, you also tell them other things to do, nutritional and lifestyle modification. You just know what suits you and go for it, because you don't want stressful situations for them. It can trigger their symptoms.
We'll go on a quick break now, and when we do return, we'll pick up our conversation with Dr. Mariam Omishori Bakare, where we'll explore more perspectives on the autoimmune disorder lupus. Don't go away. We'll be right back. Welcome back. If you're just joining in, this is the program Healthy Living on Trust Television. I'm Aisha Salihu, and we have been conversing with Dr. Mariam Omishore Bakare on the autoimmune disorder. Thanks so much for staying on the program with us.
Thanks for having me.
I'd like for us to now go into, treatment, because we've talked about the causes, we've talked about the problem, so we have to seek solutions. So what would you say are the treatment options for this particular disorder?
Okay, thank you, Aisha. Let me reframe it and say the first question that we doctors get is, do you have a cure for this thing that it's you just diagnose something, so do you have a cure? Let me start like that. Oh well, for lupus, you can't really, place your hands and then say, okay, just take this and you're good. That's the end. But it can be well managed, especially when you diagnose early. You need early diagnosis, you need compliance by the patient, you understand, and then follow up. Because when you say something is not something you keep and you can cure it, but you can manage it, it means it's going to be a long-term management. So for treatment, they are usually symptom targeted, one, and then you individualize. It's not a one size fits it all. Like, okay, A has it, B has it, everybody just take this. No. Because, like I said, the spectrum is such that someone may, quite all right, been diagnosed with lupus, but it's just, for one reason or the other, it's not just exhibiting most of the very weird signs. So you don't go to the highest level of management for such a patient. You just stay minimal. There are some categories of medications we use. We have the anti-inflammatory, the non-steroidal anti-inflammatory drugs. Some common ones, you have diclofenac and all of that. And then we have some that we call disease-modifying anti-rheumatologic drugs, DMARDs. Those ones, just as the name implies, you can't kill this, but you can modify how it affects your patients. You can go to that. We have another class of drugs that the one that I really want to mention, because there's some certain drugs that they have a place in cancer management, but we use it to also treat lupus patients. And some of the patients, part of the problems or challenges they run into is they go to some pharmacy stores and they're like, do you have cancer? Why are you taking this? And that's the end. That affects their compliance. They may not have a trust in their doctor, even though they might have been, told that this is it, but this is why we are using it. Some of the drugs are those ones that said you can't take in when you're taking these medications because it can actually harm the unborn and all of that. So we have that various categories and levels of medications. And they are the beautiful ones that are coming up, or they have been around for some time. We call them biologics. When you say biologics, it mimics what it's in your normal physiologic system to address this disease entity. They may be pretty expensive, but quite a number of people access that and they do well on it and they are able to, achieve and it's a close to normal life and have quality life. They can really do very well. That's the truth. It can be well managed. People have testimonies about how they were and how they are based on their management.
You did talk about compliance and the fact that when some of these patients go to the pharmacies to get some of their medication, there's this, will I call it maybe stigma, or maybe stigma is too much of a big word, but there is this hesitancy from the people attending to them. But these medications, aren't they supposed to be prescribed? Because I believe if you're a patient and you go with a doctor's prescription, I don't think any pharmacist should.
I'm a doctor, let's say you're a patient, or I'm a patient, you're my doctor. I come to you, you assess me, and then you give me a prescription. Okay, maybe I couldn't access that medication in your facility. If I go out, you may not be the one to tell me, oh, go to a particular place. So sometimes they may end up in some substandard pharmacy stores, and I've never really heard of, even if you tell them, they said I have lupus, and I have to take methotrexate. They may not have been aware of that, and then they misinform the patient. And to really take the word stigmatization from your mouth, it's not from the pharmacist or from the society. When it comes to lupus, one of the things that happens is, like I said, it's not just malaria. A lay person on the street knows that malaria, max, they tell you 3 days. In fact, the lines in the advertorials is after 3 days you don't get better, seek doctors, advice, or go see your doctor. So for lupus, it's not like that. So it means it accounts for absenteeism from school, from work. That's where the stigma usually comes. And then family. Sometimes they are in a kind of in a state that it's so terrible that they've lost weight, their blood level is low, they really can't do a lot of things for themselves. So if you don't have that strong family support, if you don't have that strong societal support, the patient may really not do very well.
I've seen a lot of testimonies of people coming out to talk about what they're dealing with at the moment, and then they also talked about the stigmatization they had to face, people looking at them, what's on your skin, what's on your face, and all that. I'd like to know, as an expert, how do you handle these patients who perhaps may have suffered, would I say, low self-esteem, or they're reluctant to want to access more care because they know that the society already faces them with stigmatization, there is discrimination, it's as if they are not even part of the society. How do you address this? Is it more on awareness, or how do you go about it?
Like I told you earlier, I've had the opportunity of working with a rheumatologist, and in outpatient clinic where you do for follow-up, you just have to be patient enough to listen to them. Aside, it's not something, it's not business as usual. Like, okay, yeah, that's the drug. Okay, just go to the pharmacy, get your drugs, and all. You need to interact. What has been happening with you? So in this conversation, some things come up. For lupus, really, it doesn't end at the table of the rheumatologist. Most times, the multidisciplinary approach you have to give to it. Remember, we said the kidneys can be damaged. You may need a nephrologist. The lungs can be affected. You need a pulmonologist. The skin, at some time, you need a dermatologist with some aesthetic thing to be instituted. And then, of course, you need a psychotherapist. Sometimes some people are able to just take it in and put in a jiffy. They are good. They can really talk themselves out of it. But we are different. Remember I said the management, you individualize it. It depends on who you're dealing with. If it's someone you could just offer a talk therapy in your consulting room and they are good, fine. There are some you may need to go further by making an appropriate referral to a clinical psychologist or a psychotherapist. And remember, they could even have neurological affectation. They may even need a mental health physician, a psychiatrist, as the case may be. So it's a multidisciplinary approach. So for them, you give them the much of the talk therapy, the counseling you need, psychotherapy you can offer, and then you make appropriate referral so that they can, get needed help in that regard for their mental health. Because the mind and the body, you can't separate them. What is in their mind, what they believe of it, it's what they would exhume out, in their presentation. So you really need to take care of that mind. The psyche needs to be worked upon many a time.
You are in management and treatment of the disease. We talked about medication. Since people are not aware of this particular disease, how accessible and affordable would you say the medication is? Because if people are not aware of it, so that means there's no business in that area. So how is that?
No, remember I said they have different categories for the medications. And if someone come to me, of course, I would make appropriate referral. First, okay, go to see a rheumatologist so that there's always newer things being done. I talked about the biologics. Those ones are not readily accessible. I can remember then you have to liaise with the pharmaceutical company so that they can, get it for you. You discuss with the patients. It can be a direct contact before, you calibrate the management. For those that they don't really have the weird symptoms, the GMATs I talked about, the chloroquine, the anti-inflammatory, may just be fine. You understand? Those ones are readily accessible. Even some of those medications that I said, okay, they're using some cancer management and it may scare them off, the methotrexate, they are readily accessible, truly. Really, I think lupus of, this is 2023, you won't compare it to what we used to have in 2010 or something. like, oh, what are you saying? So there is more awareness. And the beautiful thing again is we have support groups. Yes, lupus has support groups. Even in Nigeria, we have NGOs stepping in at some time. We have people who are survivors who now, float some support group, just like we have sickle cell support group, we have lupus support group. I know National Hospital or where there are support groups, really. That helps. One, to access their medications, and other times for this psychotherapy we are saying, there's this pair thing, like, okay, it's not just about me. Oh, see other people having this, and they are living they're living their lives to the fullest. So it's we have quite a number of support around.
I understand that this disease has no cure, like you mentioned earlier. So let's also look at prognosis of patients, right? Or let's say life expectancy, prognosis. For a disease that has no cure, it's just management. You can only just manage. So how then would you say what then would you say is the prognosis of the disease, according to the patients, or maybe the life expectancy of whoever is living with the condition?
Okay. Lupus, really, it's not like you're talking about a cancer entity. I'm using cancer because that's like what everybody really can. Okay, cancer, it's very bad. But for it, you tailor the prognosis to the presentation. Okay. Like I told you, sometimes you have some patients, they are lucky enough to be picked up very early. Early diagnosis guarantees better prognosis. Late diagnosis could necessarily mean the prognosis won't be particularly awesome. And then the individual peculiarity about the presentation, the myriads of symptoms and signs and symptoms the person presents with would also preclude the prognosis. So you can't see a patient and say, okay, as I'm looking at you, you only have a year to live, so start writing your will. You may not be able to say that. Remember, I also said some people go into remission. Remission means, for the past 2 years, I've not had any symptoms. Some are that lucky. And all they will be left with is what we call trigger flares. They have flares based on stress or any other conditions that it's not really favorable for them. But otherwise, quite a number do well. But that's not to say we don't experience casual mortalities. Some do die as well, and some do live. But all of this thing you're doing, which I must commend you, is the more awareness we have, the more likelihood for earlier diagnosis. And when you have this early enough, you'll be able to attend to it early enough. You'll be able to step into your own management, and then you'll be able to accept early enough. Because another thing in our climb is denial. I tell you, you said, I have lupus, and then you go for 5 years, or for you to come back, and then the kidneys are damaged. So that person, ordinarily, even without any intervention, had bought 5 years. So I wouldn't have told that person you have 5 years or you have 2 years to live. They didn't even come back for anything. But by the time they are coming back now, they are bad prognosis and cancer. So it's actually based on individual presentation.
Thank you so much. We have been speaking with Dr. Mariam Omishori Bakare on the autoimmune disorder lupus, and then she did say it requires a multidisciplinary approach for management, although the disease has no cure, but a multidisciplinary approach where you have early diagnosis that can lead to better prognosis. And I hope we have taken 1 or 2 lessons from all that she has to say. For comments, contributions, and suggestions on this episode, do well to follow, subscribe, and like our social media platforms. Join us again on another episode of the program, Healthy Living on Trust Television. I'm Aisha Salihu. Thanks for watching.